Hello, everyone. My name is Grant Turek. I'm a child neurologist over in Ohio, and I have the privilege of serving as the moderator for today's talk. We have Deb Malloy and Diane Moore with us from the Developmental Disabilities Nurses Association, which has a long-standing history of working with the AADMD. In addition to that, we have Edward Jones, who will be discussing nursing care in adults with epilepsy and IDD. Deb Malloy is the current president of the DDNA, and is a certified developmental disabilities nurse, is on the development team of the Tarrytown Pharmacy. Is on the development team for the Tarrytown Pharmacy, which only services the IDD population, runs an independent IDD nursing consulting group, and helps support various agencies. In addition to this, Diane Moore serves on the board of directors for the DDNA, and Edward Jones, who's going to be taking the second portion of the talk, is a learning disability epilepsy specialty nurse over in the UK who will be helping us by sharing his wisdom from his experience caring for this population. We'll start with some brief words from Deb Malloy and Diane Moore before handing it over to Edward. And if you have any questions throughout the talk, I encourage you to put them into our Q&A box or into our chat box. I'll be keeping track of them throughout the talk so that we can address them at the end. So without further ado, Deb and Diane.
Good morning. Thank you for the opportunity. Thank you, Grant. Thank you, AADMD and all the support. And as Grant shared, we have a longstanding collaboration that we work with AADMD over the years. A lot of similarities with a lot of things with as well. As Grant shared, I'm the president of DDNA, the Developmental Disabilities Nurses Association, and we're a national association educating, empowering, and advocating for nurses that are practicing in the field of developmental disabilities. I have been on the board for about 8 years. I started out and kind of got initiated in as the president-elect for 2 years, president for 2 years, back to president-elect. And in January, I started my second term as president, and my term will go through 2024. Obviously, I have a passion for the field. I kind of got into it by happenstance. And over the years, about 30 years in the field, I have tried to get out of it, but I keep coming back. So it's kind of like Hotel California. Once you get in, you can't get out. So our mission overall, and part of my passion as far as with the field of DD and supporting nurses is also to be a resource and be able to share my knowledge and my expertise and my experiences over the years myself, but also our entire board of directors' knowledges and experiences in addition. So DDNA, our mission is to serves to educate, empower, and advocate for nurses that are practicing in the specialty of developmental disability nursing. And as our mission states, DDNA serves to educate. And we do this by we have an annual educational conference, and we have a multitude of webinars that we hold throughout the year. We have a lot of different connections with a variety of different organizations, pharmaceutical companies, and so forth to help educate our nurses in the field. We empower our members and support all DD nurses to influence the field of DD, to ensure the importance and the necessity of the DD nurse so we can ensure quality care to those that we serve. This is in part accomplished through our certification program. We have a program that certifies LPNs or LVNs as well as RNs. This is a benefit, obviously, for the nurse individually, that they can showcase their knowledge and their dedication to the field of DD, and a benefit of the agency that's employing the best of the best in order to support the individual served. We also have various councils that we engage membership in to assist in developing and updating publications to ensure practices are current and that they're in line with best practices as well. And Edward, being from England, we have actually had some collaboration with some nurses as well. And so those things, we're always looking at trying to figure out ways to enhance and move forward. And again, putting practices and things in place to help support our nurses, who in turn will obviously support our individuals. And our last mission bullet is advocating for the DD nurse. And we're committed to do so, as we know membership is a necessity to be the voice for all. And as I shared, we have various councils, and these are another means of getting membership involved in efforts to advocate for all nurses practicing in the specialty of DD nursing. But we continue to seek ways to further support and advocate for all DD nurses worldwide. So I'd like to take a minute to introduce Diane, and Diane Moore is our Executive Director for the DDNA Association. Diane has many years of experience, knowledge, and is a great resource, an expert in the field. And I'll have Diane share a little bit more about her background and further expand on DDNA.
Well, hi, everyone. My name is Diane Moore, and I'm delighted to be here. I appreciate you guys giving us an opportunity to say hi to everyone and give a little bit of information about DDNA. As Deb indicated, I'm the Executive Director for the Developmental Disabilities Nurses Association. I'm a practicing registered nurse. I've been an RN for over 40 years. Over 30 of that has been in the field in the specialty of IDD nursing. And like Deb, I got into it and like so many IDD nurses, I got into it and I kind of laugh and say I needed a day job. And because I was an old ICU nurse and I absolutely loved that, but I had young children and I needed something that worked better with my family. And so I knew someone who was a program director actually at a children's facility. And she said, well, why don't you come and see about working here? And I did. And as the story goes, I kind of fell in love, and I've not had any great desire to go anywhere else. So it is my passion. As Deb mentioned, I too am certified in the specialty of IDD nursing, and our certification at DDNA really does allow a nurse to demonstrate his or her expertise, their commitment to the specialty and to the people they serve. And it's a great way, I think, for agencies to also demonstrate their commitment to the people that they're supporting by using certified nurses. There is the process for becoming certified includes a good amount of experience, hands-on kind of practice in a specialty, and then as a part of that continuing education or certification is a continuing education requirement. I think one of the things we all struggle with, and I know AADMD is trying to address this from the medical side and dental side and even nursing, we're trying to as well. But one of the real challenges, as everyone knows, is you get very little exposure to or information about intellectual and developmental disabilities in your curriculum, whatever area of healthcare. And so you come out really completely unprepared to support people with IDD. So that's one of the reasons that DDNA really focuses a lot on education. As Deb mentioned, we just concluded our 31st annual education conference event, and quite successfully. We're looking forward to next year, as always, but it really was a great event this year. And that's one of the key pieces as we address that part of our mission statement. And again, we do webinars, as Deb mentioned, throughout the year. We also have forums on our website so that a nurse who's practicing out there can pose a question to someone who might have some experience. They can respond and really serve as a resource to one another. Because as a lot of people realize in nursing in IDD, oftentimes that nurse is operating or functioning in isolation, quite frankly. They may be the only healthcare professional employed by an agency, and so it can be a fairly lonely kind of even daunting task at times, because you don't have a colleague that you can walk down the hall and discuss something and get some feedback. So DDNA, we really serve to try to be that resource to those nurses. We appreciate our collaboration that we've had over the years with AADMD. Obviously, it's some of the other professional associations that are a part of that IDD health spectrum. We also collaborate with them. So that's another way we're really able to advocate for the specialty itself as well, is just by those connections and making information available, making sure that nurses are aware of the other resources that are available on the spectrum of health support for people with IDD. So again, it's my pleasure to be here. Thank you again so much. If you have any questions, please feel free to contact us and we'll do our best to answer.
Well, thank you, Diane, and thank you, Deb. So, thank you very much for the words on the DDNA and what you guys are working on and all this collaboration through the years. I'm looking forward to continuing to work with AADMD myself as we continue this collaborative relationship. So, without further ado, I'll hand the microphone over to Edward Jones, who's an epilepsy and IDD specialty nurse. Edward, would you mind telling us a little bit about what that means? And then we'll go into the talk where you can share some of the wisdom you've gained over the years.
Yeah, no, that's fine. It was interesting to listen to your speakers then, because I suppose my path is a little different in as much that in our country, you can train directly as we call them, learning disability nurses, or I suppose intellectual disability nurses. So that's my background. That's how I was trained, and then I kind of specialized in epilepsy for people with learning disabilities at a later stage. But yes, I think, kind of it was interesting. I think the point I picked out as well there was that working in isolation, I think is very true, that, you kind of obviously having to make a lot of decisions on your own, aren't you? Some very kind of responsible decisions, really. I think that was a key take-home point from what was just said, and I suppose that's the beauty of the having the association. So yeah, my background's obviously, so it's learning disability nurse was my original training, and then the epilepsy has come alongside, obviously, because it's such an important comorbidity in people with learning disabilities.
And then I believe you have some, I believe it was case presentations that we talked about that we were going to.
I do. I apologize because we had a few technical problems getting on, so I'm going to try and share my presentation, and if that goes wrong, I'll just talk through it. So let's have a look. Right.
Well, if we are having some difficulties, we do have Courtney and Jamie here to help us out with that. So
okay, it's just not a presenting. It's not something I usually do through this medium, so it's just trying to find out how best to do it. Perhaps if I were to email my presentation quickly to somebody, could that be then?
Yes, feel free to email it to me. This is Courtney, and okay. You can go ahead and just start now, and then I'll pop it up as soon as I get it.
Okay, so if everybody's okay, well, I just do that quickly. So Courtney, I think I've got you. There we go. Apologies to everyone for the slight delay.
No worries, this happens from time to time. I'm sure everybody in the modern day is familiar with this difficulty. So. Oh
yeah, thank you. There we go. I'll send it. Right, I've sent it across now. I'll make a start. I'm used to having to think on my feet. So yeah. So hello to everybody. It was nice to see as your names and destinations where you're all living is fascinating. Seeing kind of geographical distance, and I suppose I'll start by that with where we are. So obviously our services in England, in the northeast of England. If I think probably in terms of bits to help you locate us is if you know York is probably the most famous places. There we go, lovely. And am I able to kind of move the screen on, or
I think what you'll have to do is say next or adjust.
Ask Courtney to move us on. Thank you, if you would be happy. There we go. Courtney, is it okay if we move on?
Yes, sorry, I gave you remote control access.
Oh, lovely.
Yeah.
Okay, let's have a look. Sorry, I'm just getting my head around this. And okay, so we should. No, I'm struggling with that a little bit. I apologize.
Not a problem. I'll do it.
Lovely. Thank you. There we go. So there we go. That I've isolated where we are for you. So obviously the county in red is us. So kind of we go from the North Sea to kind of halfway across the M62 motorway. If that may not make much sense at all to you. I suppose your most famous cities nearby would be York, possibly. If you go a bit further west, Manchester, Liverpool. And if you go on to the next slide again, Courtney, that'd be really appreciated. Okay, so that's the kind of a kind of closer look at where we are. So if you look on the map at the bottom, you can see the Humber, the River Humber, which is, you know, kind of, yeah, that's it. So just above there, you can see Hull. That's where I'm presenting from as we speak. So we've got Hull, which is kind of like it's a city of about 250,000 people, that's kind of within a bigger county, which is the East Riding of Yorkshire. So our territory, our patch, if you like, is Hull and East Yorkshire. So it's kind of, I suppose, from say Hull to, if you see Goole, which is a kind of about 30-mile drive that way, and then out to the coast on the other side is kind of about a 20-mile drive, and then we can kind of be anywhere in between. So that hopefully gives you some kind of idea of where we're talking about. That's great, thank you. Yeah, that's fine. So I'll talk a bit about our team. So there's two of us, two learning disability epilepsy specialist nurses. We're both what are called non-medical prescribers. I don't know if you have a similar system in America, where basically we are nurses who can prescribe medications. So we prescribe anti-seizure medications, very occasionally some other medications as well, but mostly really anti-seizure medications. We work with a consultant neurologist. So it's a strange system, because in England you have NHS trusts, so National Health Service trusts, and we belong to one trust. And the consultant belongs to another trust, and we kind of buy in his services kind of 2 times a month. So 2 afternoons a month, the consultant neurologist works with us, and we do clinics together. So 1 face-to-face clinic and 1 Teams clinic. And obviously we have a secretary to help keep us all organised. But that's the kind of the team. So that's lovely. Thank you very much. And we're based within a wider learning disability team that has consultant psychiatrists, psychologists, other kind of more general, if you like, learning disability nurses, and the rest you can see. So occupational therapists, speech language therapists, obviously within that, us two, the 2 epilepsy specialists, and then all of the admin staff that keep us organised and, you know, kind of sane, really. So in terms of the work we do, we're supposed to be a 9-to-5 service. Doesn't really work out like that. I'm sure that's much the same for everybody else. We're supposed to be Monday to Friday, which we're better at kind of managing, but yeah, you know, kind of certainly depending on the day, work starts somewhere about half past 7 in the morning and can be anywhere through till whenever at night, because it's just, you don't know the crises that emerge. We are a service that we work with people from 18 years of age upwards, so really from 18 until we're very unlikely. We don't really have the opportunity to discharge many people, because it's not really, as we all know, good discharge people. Tends to be that we often work with people all the way through to the end of
Did we lose Edward? Can anyone else hear him?
I think we're having some connection difficulties, Edward. Are you still there?
I can hear you.
We heard that. We heard you say, I can hear you. Oh, I think you're back.
All right.
Oh, good. Okay.
Now
I don't know. I've no idea where I cut out, but I was telling you a little bit about the service. Perhaps if you could go back one slide just quickly, if that's okay. Yeah. So just to recap briefly, so we're a service from 18 to the end of life, really. We have people with really very complex comorbidities, which I'm sure would make sense to all of the audience, really, from very profoundly disabled people. Often we work with people with very complex mental health conditions, often comorbid autism and anxiety and a lot of dementia. So a very kind of complex, kind of range of comorbidities, really. We work really closely with families, with carers, with both paid and unpaid carers, and often, as I'm sure again you will appreciate, there are often our eyes and ears, and we do value the importance of our work with families. The service was established, I think, around about 20 years ago by one of my predecessors. I think there's been about 4 of us in total since who've done the job. So it's, kind of tends to be the kind of job that people stick around and want to do for a long period of time, possibly for all the reasons that our guest at the beginning said about, you kind of fall in love with the work. We've obviously, like most, probably all health services, been massively affected by the pressures of COVID-19, and I don't know how aware people are of our health service in this country, but we've kind of going through awful pressures, really, in terms of waiting lists, financial cuts, and there's outstanding kind of issues in terms of striking and things like that for nursing and doctor staff. So it's really quite a complex situation again. So what we're trying to do where safe, and I say obviously where safe is key, is to prevent hospital admissions, but obviously, kind of that then mounts the pressure on us. So we have approximately 320 patients between the two of us, so roughly 160 each. So just to break that down a little bit in terms of numbers, we have approximately 20 or so people with Lennox-Gastaut syndrome, although probably more who have either unrecognized Lennox-Gastaut, probably. In terms of tuberous sclerosis, we have about 6 people. Dravet, we have 3. I've had to update that this morning because we've got somebody coming through in the next week or 2. A lot of people with Down syndrome who, as they're kind of heading into their 40s, 50s and beyond, are beginning to show signs of dementia. We work a lot with people with vagal nerve stimulators, and we work with our consultant neurologist I mentioned at the beginning, in terms of people who use cannabidiol, so kind of cannabis-based medicine with what's been very successful. The other thing that we're working a lot with people is a new drug in our country anyway. I don't know how it stands with you, but cenobamate is one that we've used in the last year or so quite successfully. Okay, so just to kind of give you a bit more context, so we have clinics every Thursday. So every Thursday of the month we do a clinic. 2 of those will be independently run by nurses, so we can do that over the telephone. We have in addition, one vagal nerve stimulator clinic a month, where obviously we kind of check, review and optimize settings. We do home visits as and when required, depending on the needs of patients, and we also help organize and run and kind of really get people in to see the neurologist. In terms of some of the education work we do is buccal midazolam training with families, with carers, and kind of just as and when necessary, really. Epilepsy training is something we need to kind of get back to. It was something that pre-COVID was kind of ran freely, and obviously with restrictions on numbers that became a non-possibility. It's obviously, and it's getting back to that, really, which is one of the last things we really need to kind of recover from, really. We do little bits of vagal nerve stimulator training that's obviously fairly straightforward, and kind of and a lot of the epilepsy awareness training will also be for new hosts as well. Sorry, new colleagues is what I meant. So just to give you a bit more context, so we regularly update, review epilepsy management plans, so things like prescription of buccal midazolam, clonazepam, clobazam, things like that, in managing seizures and seizure clusters. We look to obviously constantly through clinics review and optimize, and where appropriate deprescribe anti-seizure medications. We sometimes will also look at things like deprescribing and prescribing antidepressants, and in consultation with the consultant, things like optimizing medications to kind of manage the symptoms of dementia. We're also kind of constantly monitoring things like people's concordance with medication, which we'll come to in a minute with one of the case studies. A lot of our work is coordinating with other disciplines, and an awful lot of safeguarding work, just because of the nature of the vulnerability of many of our patients. Okay, so that's a whistle stopped all through that one. Okay, so case studies, probably a good time to go on to all of the. I'm going to do 3 case studies of people I still work with closely. All of them have been given a pseudonym, just for kind of kind of dignity, really. So the first chap I'll call Terry. He's 43 years old, very interesting man, very his learning disability is relatively mild, but he's a very complex individual, and I'll kind of give you a bit more context. So he, to my knowledge, has always lived in the kind of, certainly in England, and mostly in the in our area. He has very complex delusions and paranoia, where he believes he fought in the Vietnam War. He believes that he's fought with the mafia. He's fought in cage fighting and things like this. Is kind of quite a complex presentation, but this is deemed by other health professionals that it's not really a mental health problem. These are not, they're more perhaps fixed beliefs that kind of, I suppose, help him manage day to day in terms of maybe lacking an identity, lacking a role. He believes he's half robotic. He does have a vagal nerve stimulator in situ, so kind of that makes more sense to me than kind of it may at first. He believes he's kind of got an exoskeleton, and but because he sees himself as half robotic, he kind of believes that half of his medication is inappropriate, so he kind of stopped taking about 50% of his anti-seizure medication, and perhaps unsurprisingly ended up in status epilepticus and having to be put in an induced coma. At the time of writing, he was planning to withdraw from further anti-seizure medication, which he did to some degree, and basically through a lot of kind of collaborative work, it was deemed that really the only way to ensure his safety in the short term was to kind of what we call section somebody, to kind of put somebody under the Mental Health Act into a place of safety. So he sees medication as harmful, he sees it as poisonous, he recognises some of the side effects that we would all recognise in anti-seizure medication, but also believes that it is poisonous and dangerous. So yeah, quite an interesting character, and probably the responsibility for me lacking even more hair because of the worry and stress. I'm working at home. I can just hear my daughter's fallen downstairs, but my wife's with her, don't worry. So if you can hear some crying, that's what's happening. Yeah, and I think a lot with Terry is that the reason that of withdrawal from medication is really kind of, there's very little in his life he can control. And so the medication and food are things he can control. And so he refuses those. We'll move on to case study 2, but I'm more than happy to kind of discuss further things if that's fine. So I'm ready to move on. Thank you very much. Okay, so the next one is a chap called, well, again, not his real name, David, 45 years old, quite a mild learning disability, which poses its own challenges, I think, because we have, we go by what people are able to do under the Mental Capacity Act, and sometimes that will include unwise choices. And he was kind of a classic case of this, really. So spent large portions of his adult life homeless, living in a graveyard, living in the shop doorways. He would often self-medicate with cannabis and was not particularly regular in terms of taking his anti-seizure medication. Interestingly, I mean, it took me a long time to trace him. And one day, I mean, I spent months and months leaving voicemails on a phone I believed to be his. And one day I got a phone call, just a random phone call from a woman who explained that this person actually was living with her at the time, and wanted to make contact. And so we did that. He was well known to the criminal justice system, so we met at the probation office, and kind of, I suppose, a safe place of safety, really. But it clearly had a very long history of criminal convictions, but he wasn't really a dangerous person. Was kind of more made some unwise choices. Anyway, through this relationship that he had, he achieved a period of greater stability, was taking medication, achieved better seizure control, and then after that he went to prison for an offence committed, and then not really he didn't do much to help himself in terms of avoided skipped bail and things like that and what have you. So anyway, he went back to prison, but actually prison in some ways was quite a good place for him because he was stable, really pretty much seizure free. I'd increased his medications while he was in prison just because actually we got more of an accurate recording of how often he was having seizures. So he was released from prison in November of last year, and very sadly by December of last year he was dead. He died. Still not entirely sure of all the circumstances. It would seem he hit his head. I'm not sure if that was in seizure or if he was, kind of in some ways else intoxicated. I don't know the answer to that, but either way, he did go into massive seizures, was taken to hospital, but didn't survive, which is very sad. Anyway, so last one, I'll promise to cheer you up now. Okay, so this lady, again, not a real name. Helen is 68. She lives alone, which is quite kind of, again, not a particularly very safe situation. So I'm working closely with social work services to see if we can change that situation. So she came to our service from a different service, and she'd not really been able to engage with that service because we do make much more reasonable adjustments. I will go to her house rather than expect her to turn up to an appointment. Anyway, she lives alone. When I first met her, I was kind of really struck. She seemed very, very, very profoundly disabled, but she's got tattoos all the way down her arms and legs, and you kind of think to yourself, it would be very unusual for somebody that disabled to have such an array of tattoos, because you kind of think, I don't think she'd have had the choices to make those choices, the capacity to make those choices rather. Anyway, so I increased her vagal nerve stimulator on the basis that, you know, this would do her hopefully some good. I came back about a month later, and as I'm sure we all do with even with people we don't think will speak back, I kind of entered the house and shouted hello. And I was really massively taken aback because she shouted back, and, you know, kind of, she's a very able, articulate lady, clearly still with a learning disability, but within that, a very capable person. And I think she'd just been having so many seizures that really the vagal nerve stimulator had been so not optimized, that really optimizing it has really helped to make a massive difference, not only to her seizure control, which has generally been much better, but to her injuries. If you were to see her, you kind of see that she's got the face of a boxer, really, you know, kind of nose broken so many times through atonic seizures, you know, little cuts in her eyebrows. And really, she's not had that many. She had a couple of injuries since, but that was in extreme weather, very hot conditions in this country last July, where she'd had a couple of seizures. She's more alert, she's more awake, you know, kind of, it was a really nice story. And I would increase her vagal nerve stimulator settings more, but she complains that when the settings go a bit higher, that it kind of radiates in pain in her teeth, which I have discussed with the vagal nerve stimulator company, and they assure me that this shouldn't happen, but it seems to happen for her. And so anyway, so we've left the power where it is, but it's still, even though I don't think things are optimized quite as I'd wish, they are much better than they were. Just to kind of give a bit of background, she's very, very phobic of the dentist, and I don't think she's been in about 20 years. So clearly that's another piece of work that needs to be undertaken. But yeah, so that's, I suppose, 3 examples really of patients that we see, and there's you know, clearly, as we said at the beginning, countless other examples. So as I said, you know, we are a service of 2 people, 2 nurses, and 1 consultant who joins us twice a month for 2 half days. So really, obviously, the work falls on those 2 nurses all the time. Just like everybody else, we've dealt with a pandemic, and, you know, kind of how that's massively affected services. We are working through difficult, challenging times in the wider National Health Service in this country. So we recognise that our service is far from perfect. We recognise many ways in which we wish to improve, and, you know, often that's frustrated through just not enough hours in the day, and, you know, kind of, but I suppose just to kind of give you some ideas of areas where we see our service improving. We have quite a few patients who have comorbid epileptic and non-epileptic seizures, and quite often it's very challenging for carers to differentiate between those seizure types, and really quite, kind of a fascinating, difficult piece of work, really. We're just at the beginnings of working more closely, more collaboratively with our colleagues in psychology, just trying to set up a pathway for non-epileptic seizures. But I suppose that psychology pathway will also enable things like people to kind of manage their feelings about either having a long-term condition or managing a family member with a long-term condition. So yeah, that closer kind of collaboration with our psychology colleagues is a thing that we're really looking forward to doing. I said to you at the beginning that so much of the epilepsy awareness training had to be kind of rightly put on hold because obviously the inability to social distance during those events, and that has become something that it's probably one of the last things really that we haven't yet re-established as a team, and that's through various frustrations, really. Not so much things like social distancing now, it's kind of working out practical things, but that's a key piece of our work that I believe is missing, really, because of that importance of education in epilepsy. We know it's a very complex condition to understand, and that it can be quite a scary condition for people to kind of work with, and so the more information really is more power to people, isn't it? And I suppose the last point I'd make in terms of where we are aware of our shortcomings of a service is kind of auditing in order to kind of to prove the progress made with people, but often we're so busy working with people that we don't have time to kind of step back and look and work out how to further evaluate and kind of evidence what we have done. So, kind of definitely a failing of the service. I think that's the end of my presentation, which kind of takes us to, I suppose, gives us a few minutes maybe to discuss things, if that's okay.
Yeah, that'd actually be wonderful. Thank you for that great talk. And I did want to address one of the questions you had kind of earlier in your talk. You mentioned yourself as a non-medical prescriber.
Mm.
The correlation to that over here, I guess the phrase would be across the pond, would be we have physician assistants who work as medical prescribers as well as nurse practitioners. And that pathway is varied depending on how you get there. Nurse practitioners usually start off as registered nurses, but then we also have a separate pathway through physician assistant training, usually working closely with a physician of sorts. And that actually leads into one of the questions from the audience. There was pardon me if I butchered the name, I'll do my best, Lior Natanov, who was asking about different resources for nursing certification. Will there be more researchers such as further training in epilepsy that you could recommend? It really depends on your background and how you're going about getting there. If you are a registered nurse, I would point you more towards the Epilepsy Foundation, the epilepsyfoundation.org. They have resources for nurses interested in learning more about epilepsy, about learning more about managing epilepsy. In terms of the nurse practitioner track, I know with my own nurse practitioners that we've worked very closely together with the epileptologists in our group to bring them up to speed and get them educated. Usually they're coming over from a different type of practice, sometimes from surgery or orthopedics. So it's learning the algorithms and working closely with the physicians in your practice. And depending on where you're at, that could also be very different as well. I imagine that the process was different for you, Edward. Could you speak a little bit about the training that you went through?
Oh, absolutely. Yeah. So I did my nurse prescribing, or I suppose a couple of years ago, again, during the pandemic. So that kind of threw up challenges because obviously not able to meet face to face with many of the practitioners that you would have chosen to, but obviously that was an obstacle overcome. So certainly here we do it through university education, so through kind of either last year of undergraduate or first year of postgraduate training. A Wednesday, and obviously, like I said, there's lots of outcomes to achieve. Obviously, looking at things like, I suppose, pediatrics and older adults and kind of.
Edward, I'm sorry to interrupt, but we're having a few more connections.
I mean, mine anti-seizure medications, and within that, really a kind of relatively small cohort of anti-seizure medications that we use regularly, but I will also kind of, depending on the situation, we do some kind of prescribing in terms of some anti-anxiety medications and things like that, just because of the comorbidities of people's anxiety and seizure and what have you. So sometimes the way to solve the seizures is actually through the anxiety rather than through the epilepsy. And like I say, we'll often oversee things like dementia medication as well, in consultation with the neurologist.
Well, thank you. And it looks as though Deb is also trying to answer that same question. And I would like to invite you back to share your words on that, Deb, if you're available.
Yes, I was actually looking at, I was looking at the response in regards to the certification piece of that. And if you go to ddna.org, on the homepage, there is a section that references certification, and you can get the certification requirements from there. In regards to training and information, it really is a lot of practice space for the certification exam. There's requirements as far as with the number of hours and working with individuals with IDD. The resources as far as kind of studying for that, a lot of it, again, is practice based. However, there are several different resources and things that people are interested in. You can just reach out to DDNA, and you can do that by just contacting us at board@ddna.org. The other thing is that we also hold, and Diane does in conjunction with Nanette Robo, who is a pharmacist that's been in the field of IDD for years. We hold a boot camp in preparation for the certification exam as well. So that's another resource for that. So hopefully I've answered that question for you. And thank you for who brought that page up.
No, wonderful. Thank you very much both for your words on that. The other question that I wanted to address, Edward, was it seemed as though your second patient really benefited from a structured environment. And we see that too with our patients with developmental issues and learning disabilities, and especially if they're in a more tumultuous environment, if there's family turmoil, they're not getting their epilepsy medication, they're winding up not doing as well. And there are a variety of different models for which individuals are put on a more stringent role. And it's unfortunate your patient had to go to prison to find that regimented process. But what other options are there for those in your area for more of a regimented lifestyle, or at least that you could encourage your patient to pursue?
Okay, that's interesting. I mean, because yeah, I think really his case is an awful one, isn't it? It's kind of, it's really tragic actually, and like you say, the only real times of stability were, one, this relationship, and two, incarceration, which neither of which were sustainable. And going back to the case study one as well is quite interesting, because as it stands, this guy who was half robotic and refusing half of his medications. He's currently he's being detained under the Mental Health Act in this country, in an assessment and treatment unit. And yeah, again, that's offered that kind of bit of stability, really. I think in terms of, I think some of the difficulties with the homeless chap that I mentioned was that he fell between lots of services, that he was in some ways, his intellectual disability was mild, and so people felt that he could cope on his own. And actually, I think that was really a lot of the downfall, and that often mental health services wouldn't get involved because they saw him as somebody with a learning disability. So he kind of often really fell between services, which is, you know, kind of incredibly frustrating and incredibly sad, really. So in terms of how do we manage, I think, you know, kind of like you say, I mean, one possibility is things like a short-term thing, that detention under the Mental Health Act, but it's obviously that, you know, and then we do have things like with people who are in the community, like what's called a deprivation of liberty order. So somebody who can live in the community but with deprived of certain aspects of their liberty, so perhaps behind a locked door, or only being able to access the community with another person, with a carer, or such like. So those, I suppose, are examples of how we, you know, manage people who are risky and dangerous either to themselves or to others. But yeah, I think sadly, certainly case study 2 is an example of where it didn't work. It went really sadly wrong, and that's, you know, kind of something that, you know, kind of, yeah, stays with you, doesn't it, when you have somebody who, you know, however hard you try, things don't quite work out, and it, you know, yeah, very sad. No.
Well, we have time for, I think, one more question, and there is one that I'd like to pose to Deb, if that's all right. And Deb, my question for you is, with all the different things that you're working on with the DDNA, all your different collaborations, is there one project that you're most excited about that we can look forward to hearing about more in the future?
Well, I think one of the things for sure is, you know, we're always looking to expand and to offer more CEs for our nurses, getting certainly more members and getting those members involved in the various activities and things that we're doing, collaborating certainly with AADMD and other organizations to help nurses and docs. And Diane spoke about the curriculums, and we're really working on trying to get some engagement from that aspect as well, and get more about IDD nursing and IDD in general in all of our healthcare curriculums as well. I think, you know, for me, I think just the biggest piece is having a voice, having nurses to support so we can be a bigger voice, and helping to educate and share our experiences and our knowledge with folks.
Well, amazing. So that really concludes all the time we have for today's talk. I want to thank Edward and Deb and Diane for joining us and sharing their words and experience. This is a reminder for our audience that this was made possible through an unrestricted educational grant from Jazz Pharmaceuticals. And this talk through the AADMD is also done in conjunction with the International League Against Epilepsy. We have been joined by Seth Keller, who is one of the previous presidents of the AADMD, and he usually likes to hop on and say a few words. So, Seth?
Yeah, thank you very much, Grant. And thank you very much for our speakers. I'm a neurologist, and this whole webinar series has been near and dear to my heart. And definitely having nursing care, nursing supports. I mean, not to butter up my colleagues on the call here, but oh my God, I mean, it's such a team effort, and we really do rely on each other and help each other. Integrative care, holistic care, supportive care, call it whatever you want to call it, but definitely people with seizure disorders, epilepsy, amongst a lot of other health issues, we definitely need to communicate and work together as a team. And this is just an example of you guys coming on and really talking about it. So again, I just really came on to really thank you all so very much, and the audience that came on. And this is definitely a global international conversation, as you can hear by who's on this call. So we definitely believe very strongly in the ADMD about comprehensive care and support by working with other organizations. And Deb, as you're saying, ADMD and DDNA, God bless you. Yeah, we're definitely there, and we want to continue to work together. And Edward, thank you very much. Also, we're going to definitely do more together. So Grant, I'm going to turn back to you. But again, thank you, thank you, thank you.
Well, that concludes our time today, and I'd like to invite all of the attendees to join our next webinar on July 25th at noon Eastern Standard Time, where Dr. Suki Ko is going to be talking about assessment and diagnostics in the epilepsy and IDD population. So without further ado, I hope you have a wonderful day.
Thank you all.
Thank you.
All right, thanks everyone. Goodbye.
Thank you.